Thanks so much for having me here. I'm a PhD student in epidemiology at West Virginia University. Until next week, fingers crossed. I actually presented at SEB in 2012, and back then I was just about to begin my PhD program, and I presented on Appalachian health disparities with a promise that I would go out into the field and collect some data on which herbs people were using for chronic disease. So because of factors that are specific to Appalachian health, I chose to focus on chronic pain. I have no conflicts of interest to declare. The NIH funded my work through a training grant. Chronic pain is an unresolved public health issue. It is pain that lasts over 3 months, and it affects over 20% of adults in the United States. It costs us so much money. It comes down to about $2,000 per person in the US each year. And it's poorly managed with available treatments overall. And this contributes significantly to the opioid epidemic that we're facing nationally, but particularly in Appalachia. Overdose death rates in 2010 were more than double the national rate in West Virginia. And the national rate of opioid overdose deaths have quadrupled since 1999. So we know that herbs have been used in Appalachia for pain. Pain-related disorders are also the most commonly reported conditions for which patients use complementary health approaches, which include herbal use, obviously. And herbal use is so popular in the United States. We all know this. It hovers at about 18% roughly for the last decade. And we also know that many herbs contain anti-inflammatory and analgesic properties. I did a preliminary lit review in preparation for my field work just to see what kind of herbs people might report, and I identified 101 unique herbs that were used for rheumatism or analgesia. But from an epidemiological perspective, few population-based studies have assessed the prevalence or correlates of herbal use in pain populations. There have been 2 studies. Neither of them were done in Appalachia, and they combined herbs with other dietary supplements. So the numbers are a little fuzzy when you get into that kind of misclassification bias. Thus, potential motivators of herbal use for pain, including pain level and prescription drug use, needed to be explored. So that was my goal. So why even use an epidemiological approach for looking at herbal use in a population? I mean, ethnobotany is great. It excels at gathering contextual information regarding the person's interaction with, ideally, a plant at its entire plant life cycle through various projects. And it provides the rationale for future additional micro and macro level research. And epidemiology, it's a little different. It excels at investigating which factors can predict herbal use in populations with, ideally, statistical precision to measure associations. So in the presence of preclinical evidence, in conjunction with what we know from ethnobotanical studies, these provide, together, they can provide the rationale for clinical trials, so it's really important. So my study purpose was to investigate the demographic, lifestyle, and health-related correlates of herbs in Appalachian pain patients using a newly developed survey instrument, the Complementary Health Approaches for Pain Survey. And we hypothesized that herbal use would be associated with many different factors, but again, we were particularly interested in pain level, prescription use, and health conditions. Just very briefly, because I know time is limited, our clinic selection process, we ended up selecting 4 clinics, 1 rheumatology clinic and 3 pain clinics in the top half of northern West Virginia. We did this through a process of, we looked online first at a few designated physician locator websites. We excluded practices that were specialty practices in other areas. Also, we were limited to 100 miles. I mean, my budget was $500 for this. So, you know, obviously I could not go further than 100 miles. We also did some pilot testing of our survey at the clinic closest to us in Morgantown, West Virginia, which is where our office is. We did pilot testing on 66 chronic pain patients initially, just to make sure our survey was adequately worded. And the stars here represent where our pain and rheumatology clinics were located. Our overall response rate was 88%, so very high response rate. We sampled, we were surveying pain and rheumatology clinic patients from June 2014 to March 2016. So we just wrapped up after nearly 2 years of data collection. So I won't get into this too much, but the survey development included a cover page, and the survey itself had 89 items. This included questions not only on herbal use, but other complementary health approaches, 11 others, including dietary supplements, yoga, meditation, acupuncture, etc. We also used something we adapted from elsewhere, a short-form global pain scale, which is it's a 20-item like kind of sub-survey that assesses pain, the impact of pain on someone's life, and it includes components such as pain level, clinical outcomes, activities, and feelings. So this was the way that we were able to gauge pain level to answer our research question. We also asked about demographic, lifestyle, and health factors, including 25 health conditions and prescription drug use. That was an open-ended question. I manually coded by opiates versus others. And the survey, it sounds long, it actually only took about 12 minutes to complete, and it was graded at a 9th grade reading level. So my team conducted pilot testing and quality assessment on both first and final survey version, because we tweaked it just very, very minorly to incorporate a couple of other questions that we were interested in after I did a clinical immersion at our pain clinic, where I learned more about the patient experience. And there were no differences in herbal use by the survey version. So I pooled the surveys for my analyses, which brought my sample to 301 people. So I used SAS. I wanted to make sure that the global pain scale was reliable, so I assessed that, and I ran a ton of logistic regression models using herbal use as my outcome, and a model each for each independent variable, the demographic, lifestyle, and health factors such as pain, prescription drug use, and that I wanted to look for in terms of what the relationships were. I also controlled for my power, my statistical power allowed me to control for only 2 covariates. In epidemiology, you can make your estimates less biased and more precise by controlling for the influence of outside relationships. So in this sense, because herbal use and other complementary health approaches are often associated with mid to higher age and higher levels of education, I wanted to control for these influences to get at more valid associations. I had some missing data in my outcome of herbal use. About 18% of the people filling out our survey didn't answer the question on herbal use. So I used multiple imputation to create 250 data sets and used a logarithm just to replicate the covariance structure and ensure that the results that we found were indeed valid. So with our results, 8% of patients used herbs specifically for pain, including 19 specific herbs. The herbs that have blue next to them were not identified in our preliminary systematic lit review, meaning this is the first time, to my knowledge, that these herbs have been documented in an Appalachian population. Ginger was the most popular with about 42% of herbal users using it. Next, lavender, peppermint, black cohosh, and then marijuana, which at 12.5% is likely an underestimate because of the sensitivity associated with self-reporting marijuana use. Additionally, those used for pain were 5 times more likely to have a bachelor's degree or more compared to lower levels of education, and concomitant use of CHA's complementary health approaches among herbal users was really high. This was particularly true with dietary supplements. Those using dietary supplements were over 10 times more likely to be herbal users than those not using dietary supplements. So with our reliability estimates, they were very high, meaning that the global pain scale was a suitable pain measurement tool for this pain clinic population. And again, our multiple imputation lends to our confidence that missing data didn't play a role in our results. Now, just a quick subset, analyses of patients only in current chronic pain. About 10% of patients used herbs, and the results were largely the same. However, those with asthma or musculoskeletal tissue injury are likely to use herbs for pain. Basically a reiteration of everything I just said, and thank you so much.